So I have no disclosures. So I will start by reminding to everyone what is the definition of different degrees of prematurity, what we mean by low birth weight and small for gestational age infants, what is the optimal timing of delivery of neonates with congenital heart disease, some of the pre-intervention considerations that we should have in order to try and improve the outcome in these patients, how we decide regarding timing of cardiac surgery and intervention, and look at specific congenital heart defects, and I will end up with the mortality and morbidity of these patients. So every neonate who is born less than 37 weeks is considered preterm, and less than 28 weeks is considered extremely preterm. And in terms of birth weight, less than 2.5 kilos is low birth weight, and less than 1 extremely low birth weight. But what I would like to draw your attention to was these two specific groups, the late preterm, when they are born between 34 plus 0 and 36 plus 6, and the early term between 37 and 38 plus 6, because during the last decade there have been studies that they have showed that even delivery at the early term period has adverse impact on the outcome of these patients. So these have higher mortality and morbidity. So now, infants with congenital heart disease may be low birth weight only due to prematurity, or they can be small for gestational age, and I will show you later how this has a different impact on mortality and morbidity. We know that more than 50 years now that patients with congenital heart disease have a 2 to 3 higher risk of being born premature and being born small for gestational age. And both chromosomal and genetic abnormalities are usually associated with congenital heart disease and IUGR. And in regards to timing of delivery and timing of intervention, both gestational age and birth weight are important factors. Now, we know that the prevalence of congenital heart disease varies with gestational age, and some recent studies have showed an inverted U-shaped curve, with the highest prevalence in infants born between 28 and 36 weeks, 12.8 per 1,000 live births, and the lowest in infants born less than 28 or more than 37. Now, the reason is not clear, so we do not know if the abnormal circulatory physiology promotes and causes preterm birth, or there is a common antecedent factor that causes both prematurity and congenital heart disease. And this is a study that included quite a large number of patients born at extreme prematurity, between 25 to 32 weeks, and they showed that in these patients, severe congenital heart disease had a prevalence of 7.4 per 1,000 hospital admissions, compared to 1.5 per 1,000 admissions in term babies. And what is interesting, they showed that different congenital heart defects had different prevalence in different gestations, and actually TAPVC, for example, is more common in terms and is very rare in preterm babies. And on the other hand, hypoplastic left heart syndrome is significantly associated with prematurity and low birth weight. Again, to support what I told you earlier, that even the early term period has an adverse impact on outcome, this study from 2014 that included more than 4,500 neonates who underwent surgical repair during the first 28 days of life showed that even being born at this period, 37 to 38 weeks, had a statistically significant worse mortality, had more postoperative complications, and longer length of stay. So it is important to avoid even this period of time if we can, when we decide about timing of delivery of these patients. So even in the neonates and without any abnormality, the current obstetric guidelines are that all elective surgeries, all elective deliveries should be performed at or above 39 weeks. So therefore, unless there are obstetric or fetal concerns, such as premature rupture of membranes, oligohydramnios, hydrops, or concerns about the status of the fetus, then we should aim for elective delivery for these infants, ideally between 39 and 40 weeks. And now that we have much higher more of the cases are being diagnosed antenatally, we should influence and try to push for this period of delivery if there are no absolute indications for earlier delivery. Now, the only maybe exception would be if we believe that early delivery with the intent to treat the neonate may offer a safer alternative to intrauterine treatment. For example, if you think that if you deliver slightly earlier and you do a balloon valvuloplasty in a critical aortic stenosis, may have a better outcome instead of waiting a little bit later, or in cases of fetal tachyarrhythmia, we may have to consider that, but again, with a great balance between benefits and risks of prematurity. Now, regarding some of the preoperative considerations, we know that abnormal hemodynamics may create a very vulnerable period for the preterm neonate preoperatively. And common complications of prematurity, such as necrotizing enterocolitis or intraventricular hemorrhage or NEC, may have further impact on these infants. So timing of intervention or even utility of intervention in these patients may be altered based on the presence of prematurity complications. And having increased risk of infectious anemia or hyperlipiduремia affects the management in terms of thresholds for initiating antibiotics, giving blood products, or starting phototherapy in these patients. This is a quite busy slide and actually a table that summarizes most of the challenges preoperatively in the patients with prematurity congenital heart disease. And I will just draw your attention in only a couple of them, just like the cerebral blood flow and hemodynamics. And we know that preterm infants have increased risk of having intraventricular hemorrhage and impaired cerebral autoregulation. They have increased risk of having necrotizing enterocolitis, and that increases even further if you have congenital heart disease, or both prematurity and congenital heart disease increases the risk of neurological abnormalities, and it is very important in premature babies with congenital heart disease to have a good imaging of the brain before they go to surgery. Now, decisions about timing of intervention are influenced by multiple factors, such as degree of prematurity, weight, associated comorbidities, and the impact of uncorrected and abnormal cardiovascular physiology on the developing organs. So nowadays that size-appropriate instruments have been developed, now that the surgical expertise has improved, the weight threshold has gone down. However, the challenges opposed by extreme prematurity are more physiological, and they cannot be overcome only by surgical skills. So that's why there is a reluctance to offer complex congenital heart disease in extremely premature infants unless they reach a weight that you can offer either palliative intervention or complete repair, or at a gestational age where cardiopulmonary bypass can be offered. I will look into some specific lesions in preterm infants and see if early or late intervention has an impact on the outcome. And I will start with the coarctation of the aorta, where we know that it is technically feasible in premature or low birth weight infants. There have been studies that they have showed that patients that were operated for isolated coarctation and they were less than 2 kilos, they had good surgical success rate and acceptable mortality, but the reported recoarctation rate was relatively high, 15 to 40%. So they need these patients close follow-up for recoarctation if they are operated at a low weight. And most of these studies have concluded that there is no absolute indication for delaying surgical repair in patients with isolated coarctation of the aorta. And this is one of these studies that included more than 150 neonates with isolated coarctation of the aorta, and 30 of them had a low birth weight, and they didn't show any statistically significant difference in the mortality and morbidity between these two groups. And I will just briefly show you one case report that I think this is the lowest weight that has been reported for coarctation repair, just to show you that sometimes we are forced to do that, even if we know that it is better to wait. That was a premature baby born at 28 weeks. It was DCDA, extremely low birth weight, 560 IUGR. Of course, initially the team's approach was to start the baby on IV prostaglandin infusion and wait as long as possible. But this baby had a very stormy neonatal period with significant respiratory failure requiring episodic high-frequency oscillator ventilation, recurrent acute kidney injury with anuria and progressively discolored abdomen. And despite all the optimal medical management, they couldn't improve the baby. So they decided to go ahead at 31 weeks of corrected gestation and at a weight of 625 grams and did a coarctation repair by resection and extended end-to-end anastomosis, and the baby significantly improved 48 hours after the operation, and they reported that at 5 months post-operatively, this baby is, from the cardiac point of view, very well, has no significant residual coarctation, only mild left ventricular hypertrophy, but of course is still oxygen dependent because of the prematurity and the chronic lung disease. So this is just to show you that sometimes we cannot wait because, and we have to take the risk and do a high-risk surgical repair even at an earlier age or weight. Now, when we look at the transposition of the great arteries, we know that the longer time we wait for the surgery, we have more risk of having preoperative brain injury and more significant preoperative injury. Prematurity and TGA is associated with prolonged length of stay in the ICU and higher risk of early and postoperative mortality. And the overall mortality in this group is about 15 to 20%. However, one study has shown that if you do palliation or you repair after the age of 30 days, then these are also negative factors and increase the mortality. So they advocate that maybe early primary repair is high risk, but the optimal surgical approach. And this is the study that I showed you. It was a small cohort, only 25 neonates of TGA that were born less than 2 kilos, and actually they had the repair at a median weight of 1.9 with a range from 1.4 to 2.8. And as I said, they showed that there was the hospital mortality was 16%, but they showed that at actually 43 months of life, the survival was about 70%, and the free of reintervention was about 73%. So they thought that this is a good outcome. Looking at a more recent study in babies with TGA and prematurity, where they included about 100 patients and 13% of them were premature, they also showed that prematurity is associated with more postoperative and preoperative complications, longer stay in the hospital, and overall higher mortality. However, when they looked specifically at the pre-op mortality and the post-op mortality, they showed that the pre-op mortality was statistically significant, and then 23% of these babies died before having any surgery, as opposed to 0% of the term babies. But if they looked at the surgical and post-surgical mortality, then there was no statistically significant difference. So they also advocate that we have to push for early repair if we can before the clinical deterioration of the patient. Now, looking at the hypoplastic left heart syndrome, this is one of the most challenging congenital heart defects, and prematurity and low birth weight increase mortality and morbidity, and even late preterm have a 3-fold odds higher risk of hospital death. And to complicate things, we know that neonates with hypoplastic left heart syndrome are at increased risk of prematurity and low birth weight, with some studies reporting that 40% of these patients are born small for gestational age. And this is a study that included almost 2,000 neonates with hypoplastic left heart syndrome, and we're looking at the impact of gestational age on the outcome, and this shows the distribution of the gestational age in this group, and almost 50% of them were born at a weight less than 3 kilos. And what they looked at was the survival to surgery, so how many of them actually survived to undergo first-stage palliation, and what was the survival to discharge after surgery. And what they found is, as anticipated, that the lower the gestational age, the higher risk. But what it is of interest to see is that when we look specifically at the survival to discharge, there was no statistically significant difference between the group 34-35 to 36-37, and they are actually chance to survive after surgery was very similar to the term, 38 to 39. So again, this group was saying that we know that these patients are high risk of not making it to surgery, but if they survive the early neonatal period, we have to push for early surgery for the late term and early term patients with hypoplastic left heart syndrome. Now, in general, premature infants with congenital heart disease have a 2 to 3-fold greater risk of operative mortality, with a group of 25 to 32 weeks having the highest risk. This is due to multiple factors, such as complexity of congenital heart disease, pre-op circulation, or the impact of the cardiopulmonary bypass on the immature organs. And we should not again forget that early-term infants are also at increased risk. What we don't have enough data, and maybe there is a room for research, is what is the risk and cause of death prior to surgery. So looking at one study about the outcome in infants with critical congenital heart disease and early open heart surgery during the neonatal period, they showed that these patients had significant mortality and morbidity at 2 years. They were at risk for cerebral palsy and adverse neurodevelopment, and significant predictors of mortality were birth weight Z-score, single ventricle anatomy, post-op ventilation, and the need for CPR. And again, looking specifically at different gestational age groups, the more premature the neonate, the higher the risk. And when we look to the extremely premature infants, born between 25 to 32 weeks, again, we're having very high in-hospital mortality, about 26%, versus 5.3 for babies with the same gestational age, but with no congenital heart disease, and versus 10.9 for term neonates with severe congenital heart disease. And the mortality range, depending on the defect, from 12% for coarctation of the aorta to 67% for truncus arteriosus. Another study focusing on the extremely or very preterm babies, and the line showing the mortality rate across different gestational ages. The blue line is in the patients with congenital heart disease, and the orange in the patients without congenital heart disease. And we see that as gestational age advances, in the neonates without congenital heart disease, the mortality significantly decreases. However, in the patients with congenital heart disease, we have some decrease, but then it remains stable. Not only gestational age is important, but also birth weight, because we can have a child that is actually term, but was born with a low birth weight or was small for gestational age. And studies have shown that when surgery was performed at a weight less than 2.5 kilos compared to patients with a weight between 2.5 and 4, this had 2 to 3-fold greater adjusted risk for operative mortality. And we also know that congenital heart disease is associated with higher risk of intrauterine restriction. Researchers are trying to find why this is happening, and there are a lot of studies ongoing, but one recent study showed that certain types of congenital heart disease, such as double outlet right ventricle, tetralogy of Fallot, and VSD, were associated with lower placental weight scores at birth, and this actually was associated with growth restriction. And IUGR is an independent risk factor for adverse outcomes. This is a very recent systematic review and meta-analysis just from the beginning of 2023, looking specifically at the weight. And what they showed is that in general, for babies who are born less than 2.5 kilos with any type of congenital heart defect, they have a perioperative mortality or mortality 30 days after discharge of about 37%, which increases up to 57% when we are talking about neonates with very low birth weight, less than 1.5 kilos. And they show different risk regarding on different congenital heart defects, which did not reach statistical significant difference, but you can see that coarctation of the aorta had the lowest mortality, 16% in these premature babies, and as anticipated, the highest mortality was in the hypoplastic left heart syndrome group, with 50% mortality in these very premature babies. Now, what else is very, very interesting is to look at the impact and the effect of fetal growth in one-year mortality. And this very nice study looked at the impact of birth weight Z-score on one-year mortality. And what they showed is that if you have significant growth restriction with a Z-score less than -0.2, then this had an adverse impact on mortality and morbidity in premature infants. But interestingly, when you go again to the early term infants at 37 and 38 weeks, they show that even smaller degree of growth restriction, so Z-score up to -0.5, had an adverse and statistically significant impact on mortality and morbidity. So it's not only the gestational age, it's also the weight and the growth restriction. But we have to think also beyond survival. We know that as we're getting better with our surgical techniques and the management of these preterm babies, that mortality actually has reduced over the last 10 years. And we can see the mortality in 2011 was 19.1 for all premature infants with any kind of congenital heart disease, and it has decreased to 11.6 in 2017. But on the other hand, the risk of major neonatal morbidities increases. Maybe this has to do that more of the neonates survive, but it is something that we have to focus on, not only on survival, but also on morbidities. And as we know, the most common morbidities in neonates is intraventricular hemorrhage, bronchopulmonary dysplasia, necrotizing enterocolitis, retinopathy of prematurity, and sepsis. And this study has showed that in babies born less than 29 weeks, about 67% of them with congenital heart disease had at least one significant neonatal morbidity. And the patients of the same gestational age without congenital heart disease was 38%. And when we go to terms, this decreased to 2.7 for patients with critical congenital heart disease, as opposed to 0.1 for the neonates without congenital heart disease. So we have to think what we can do in order to improve that and reduce the risk of neonatal morbidities. We know that the intraventricular hemorrhage has a multifactorial pathogenesis, and alterations in the blood flow, particularly in the perioperative period, influence that and can be exacerbated by hypoxia, impaired perfusion, and delayed brain maturation. There are not studies that have shown whether the strategies that we use in the prematures without congenital heart disease have an impact on the premature infants with congenital heart disease, but I think we should consider similar strategies, such as avoiding rapid fluctuations of blood pressure and cautious fluid, to give cautiously fluid to these infants. Bronchopulmonary dysplasia has an increased risk up to 5-fold, and these patients have also additional risk factors for morbidity and mortality, such as high pulmonary vascular resistance, and we do have to consider applying similar preventive strategies as in neonates without congenital heart disease, such as titrating tidal volumes, and try to avoid as much as possible the invasive ventilation and move towards to non-invasive ventilatory support. And neck, patients with congenital heart disease have 3-fold higher risk of developing necrotizing enterocolitis, and we know that in cases with severe and critical congenital heart disease, we can have compromised mesenteric blood flow, particularly in duct-dependent lesions with the risk of the runoff and the splanchnic still. And that's why it is very important to counsel these families with the premature babies with congenital heart disease about the significance of maternal breast milk, because this is the only factor that we know so far that significantly reduces the risk of necrotizing enterocolitis. There have been other suggestions, such as cautious advancement of enteral feeds, maybe probiotics, and maybe the role of enteral feeds in pre-op period, but studies still have to be done in order to support that. So to conclude, prematurity and complex and congenital heart disease represent a complex and high-risk population. We are talking about the double jeopardy group. This is very important for these patients to be managed by a multidisciplinary team, pediatric cardiologists, cardiac surgeons, neonatologists, and everyone to contribute for the better management of these patients. Timing of intervention depends on weight, gestational age, type of defect, and clinical progress, and each surgical center's expertise and preference. But delayed repair is not always beneficial, and we may not be able to wait for that. And I think we now have to focus not only on mortality, but also on morbidities in order to improve the quality of life of these patients. Thank you for your attention.